Thank you for inviting me to speak. I will present my PhD topic, which is about tissue acquisition in solid pancreatic masses. So to introduce myself, my name is Engh. I recently graduated from the Medical School of Page, and I'm now very happy to join the pancreatic cancer study group of the gastroenterology team. Pancreatic cancer is one of the deadliest cancers we have. It's usually found way too late, and there's not much we can do for it. In terms of chemotherapy, there's very little. So my vision is that if pancreatic cancer is detected earlier through better screening methods and diagnostic methods, the impact on the patients will be much lower. My mission in this is to contribute to clearer guidelines for a more efficient sampling and diagnosis of pancreatic cancer. I will chip away a little bit at this with my two meta-analyses about diagnostic adequacy of tissue acquisition in pancreatic masses. The first one is looking at different designs of needles, and the second one at different methods during the ultrasound. My first project is a network meta-analysis of needle tips. Endoscopic ultrasound-guided tissue acquisition is an emergent diagnostic method for solid pancreatic lesions. It is especially important as biological therapies are developed, and also in the case of inoperable tumors, just to actually accurately diagnose it as a tumor and decide on the chemotherapy. Approximately 10% of the samples that are made are not adequate for histology and/or cytology, and in this case, we might have to perform a resampling. However, the resampling or sampling in general is costly and it's invasive, and it carries the risk of adverse effects. So this is something that should be avoided as much as possible. There are several techniques or equipment that might reduce the need for resampling. I will quickly present these. So you could have rapid on-site evaluation where a pathologist is in the room and can detect if the sample is inadequate, in which case it can be reperformed right there. Or you can use different sampling methods which might reduce the risk of an inadequate sample, such as wet suction or dry suction. But also the needle tip design or size might affect the diagnostic yield of the sampling. And this is going to be my question. You see here the types of needles that are used. You have the Mangini type needle for FNA, or the reverse or forward beveled Westcott for FNB, as well as the Francine and fork tip, which are newer designs of needles. These all exist in different sizes. So my aim is to compare the diagnostic yield and adequacy of all the needles that are used in endoscopic ultrasound-guided tissue acquisition. The question is if endoscopic ultrasound-guided tissue acquisition of pancreatic solid masses with any needle has a better diagnostic adequacy and specimen yield than with any other needle. Population are patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass. The intervention and comparator, since this is network meta-analysis, is any FNA or FNB needle. And the outcomes are diagnostic adequacy. This is dichotomous, yes or no. Specimen yield, size and cellularity, the number of passes, or mean or average number of passes needed, and the adverse events. The hypothesis is that there is a superior needle among the needle types in terms of diagnostic adequacy and specimen yield. By answering this question, I'm hoping to aid the clinicians in choosing their equipment so that the risk of resampling is reduced. We performed our systematic search on October 15th, 2021 in 5 databases. Our search key consisted of all the brands and names of needles, and random, because we're looking only at randomized controlled trials. We started off with around 3,500 articles, got them down now to 78 full texts, of which we're currently extracting the data. Unfortunately, because it's a lot of full text, all of them randomized controlled trials, the data extraction is taking quite a time. The network we're hoping to have is this. You see here the red line is 3, or at least 3 studies for each comparison. The blue line is where we have 2, and the dotted lines are where there's only 1 comparison between the needles. So for my second project, which is about the diagnostic adequacy of tissue acquisition of solid pancreatic masses using contrast-enhanced versus conventional endoscopic ultrasound, the background is quite similar, but I would just like to explain this a little bit more. During the endoscopic ultrasound-guided tissue acquisition, endoscopy is performed and ultrasound is employed to visualize the tissues and to detect the lesion for sampling. I have a little picture here of what that looks like. So judging from this, If you use contrast-enhanced endoscopic ultrasound, this might lead to better visualization of the tissues, but it decreases the time window during which the sampling can occur, and by this it might either increase or decrease the sampling accuracy. So my aim is to investigate if this can improve the sampling adequacy of pancreatic solid masses. The question is, does contrast-enhanced endoscopic ultrasound-guided tissue acquisition of pancreatic solid masses lead to higher diagnostic adequacy and specimen yield than conventional endoscopic ultrasound? Population is patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass. The intervention is contrast-enhanced endoscopic ultrasound. The comparator is conventional endoscopic ultrasound. And the outcomes, again, are diagnostic adequacy, specimen yield, number of passes, and adverse events. My hypothesis is that contrast-enhanced endoscopic ultrasound is superior to conventional endoscopic ultrasound, and by answering this question, I'm hoping to aid the clinicians in choosing the right method during the sampling to avoid having to perform re-intervention. My preliminary search found a relatively low number of studies, which is good news for me. The search key consisted of words for contrast and ultrasound, fine needle aspiration or biopsy, or tissue acquisition, and random, because again, I'm looking at only randomized controlled trials. I know there's 3 randomized controlled trials out there, so it will be possible to perform this, and hopefully it will be rather quick with this pool. So, as you see, my planned submissions dates are January 2022 and March 2022, and here I would just like to add, I have a third project. I haven't presented it here because the topic is slightly different, and I started it before the program, but I submitted it now at the beginning of November. I would like to leave you with my quote, which is, "I don't know, and I would rather not guess." I think this is a starting point for most good research. Thank you for your attention.
Do you have any data? What is the median time from the first complaint of a patient and getting to the final diagnosis? How long does it take generally?
So currently that interval, I don't know exactly what it is, but it is too long, and we're actually working to decrease it. We're hoping to decrease it down to just a few days.
Okay, thank you. Because when the real suspicion is already over there, I don't think that would make that much difference. The delay should be before, I guess.
There is a project ongoing about this. Mine is rather not about the time and just about the actual success of the sampling.
Okay.
Yeah.
Your vision was that with your study, the pancreas cancer will have a better prognosis or something like that. I really don't know that this couple of days you can gain if you have a proper diagnosis. It will help really to improve the prognosis. The story is before.
I would like to add here that my vision, I won't be able to contribute much to it. I'm chipping away a little bit at just the diagnostic method because this is a question that needs answering. I'm hoping to contribute to a larger effort which will lead to my vision being realized. Personally, I know that my projects won't chip away too much at it, but I'm hoping just to give clearer guidelines just for how equipment should be chosen for the good of the patient.